Today we will read about delusional disorder and shared psychotic disorder. Delusions are, the question is, what are delusions? Delusions are false, fixed beliefs not in keeping with the culture. They are among the most interesting of psychiatric symptoms because of the great variety of false beliefs that can be held by so many people and because they are so difficult to treat. The diagnosis of delusional disorder is made when a person exhibits non-bizarre delusions of at least 1 month's duration that cannot be attributed to other psychiatric disorders. Non-bizarre means that the delusions must be about situations that can occur in real life, such as being followed, such as being infected, being loved at a distance, and so on. That is, they usually have to do with phenomena that, although not real, are nonetheless possible. Several types of delusions may be present, and the predominant type is specified when the diagnosis is epidemiology of the shared disorder and shared psychotic disorder. An accurate assessment of the epidemiology of delusional disorder is hampered by the relative rareness of the disorder as well as by its changing definitions in recent history. Moreover, delusional disorder may be underreported because delusional patients rarely seek psychiatric help unless forced to do so by their families or by the courts. Even with these limitations, however, the literature does support the contention that delusional disorder, although uncommon, has a relatively steady rate. The prevalence of delusional disorder in the United States is currently estimated to be 0.2 to 0.3%. Thus, delusional disorder is much rarer than schizophrenia or schizophrenia, which has a prevalence of about 1%, and the mood disorders, which have a prevalence of about 5%. The annual incidence of delusional disorder is 1 to 3 new cases per 100,000 persons. The mean age of onset is about 40 years, but the range for age of onset runs from 18 years of age to the 90s. A slight preponderance of female patients exists. Men are more likely to develop paranoid delusions than women, who are more likely to develop delusions of erotomania. Many patients are married and employed, but some association is seen with recent immigration and low socioeconomic status. Now let's talk about the etiology of delusional disorder and the shared psychotic disorder. As with all major psychiatric disorders, the cause of delusional disorder is unknown. Moreover, patients currently classified as having delusional disorder probably have a heterogeneous group of conditions with delusions as the predominant symptom. The central concept about the cause of delusional disorder is its distinctness from schizophrenia and the mood disorders. Delusional disorder is much rarer than either schizophrenia or mood disorders, with a later onset than schizophrenia and a much less pronounced female predominance than the mood disorders. The most convincing data come from family studies that report an increased prevalence of delusional disorder and related personality traits, as for example, suspiciousness, jealousy, and secretiveness in the relatives of delusional disorder probands. Family studies have reported neither an increased incidence of schizophrenia and mood disorders in the families of delusional disorder probands, nor an increased incidence of delusional disorder in the families of probands with schizophrenia. Long-term follow-up of patients with delusional disorder indicates that the diagnosis of delusional disorder is relatively stable, with fewer than 1/4 of the patients eventually being reclassified as having schizophrenia, and fewer than 10% of patients eventually being reclassified as having a mood disorder. These data indicate that delusional disorder is not simply an early stage in the development of one or both of these two more common disorders. Now let's talk about the biological factors of delusional disorders and shared psychotic disorders. A wide range of non-psychiatric medical conditions and substances, including clear-cut biological factors, can cause delusions, but not everyone with a brain tumor, for example, has delusions. Unique and yet not understood. For example, not understood factors in a patient's brain and personality are likely to be relevant to the specific pathophysiology of delusional disorder. The neurological conditions most commonly associated with delusions affect the limbic system and the basal ganglia. Patients whose delusions are caused by neurological diseases and who show no intellectual impairment tend to have complex delusions similar to those in patients with delusional disorders. Conversely, patients with neurological disorder with intellectual impairments often have simple delusions, unlike those in patients with delusional disorder. Thus, delusional disorder may involve the limbic system or basal ganglia in patients who have intact cerebral cortical functioning. Delusional disorder can arise as a normal response to abnormal experiences in the environment, the peripheral nervous system or the central nervous system or CNS. Thus, if patients have erroneous sensory experiences of being followed, as for example, hearing footsteps, they may come to believe that they are actually being followed. This hypothesis hinges on the presence of hallucinatory like experiences that need to be explained. The presence of such hallucinatory experiences in delusional disorder has not been proved. Psychodynamic factors of delusional disorder and other psychotic disorder. Practitioners have a strong clinical impression that many patients with delusional disorder are socially isolated and have attained less than expected levels of achievement. Specific psychodynamic theories about the cause and the evolution of delusional symptoms involve supposing regarding hypersensitive persons and specific ego mechanisms, which are reaction, formation, projection, and denial. Freud's contributions in delusional disorder. Sigmund Freud believed that delusions, rather than being symptoms of the disorder, are part of a healing process. In 1896, he described projection as the main defense mechanism in paranoia. Later, Freud read Memories of My Nervous Illness, an autobiographical account by Daniel Paul Scriber. Although he never met Scriber, Freud theorized from this review of the autobiography that unconscious homosexual tendencies are defended against by denial and projection. According to classic psychodynamic theory, the dynamics underlying the formation of delusions for a female patient are the same as male patient. Careful studies of patients with delusions have been unable to corroborate Freud's theories, although they may be relevant in individual cases. Overall, no higher incidence of homosexual ideation or activity is found in patients with delusions than in other groups. Freud's major contribution, however, was to demonstrate the role of projection in the formation of delusional thought. Paranoid pseudo-community. Norman Cameron described 7 situations that favor the development of delusional disorders, an increased expectation of receiving sadistic treatment, situations that can increase distrust and suspicion, social isolation, situations, situations, situations that can increase envy and jealousy, situations that can lower self esteem, situations that can cause persons to see their own defects in others, and situations that can increase the potential for rumination over probable meanings and motivations. When frustration from any combination of these conditions exceeds the tolerable limit, persons become withdrawn and anxious. They realize that something is wrong, seek an explanation for the problem, and crystallize a delusional system as a solution. Elaboration of the delusion to include imagined persons and attribution of malevolent motivations to both real and imagined persons results in the organization of the pseudo community. A perceived community of floaters, this delusional entity hypothetically binds together projected fears and wishes to justify the patient's aggression and to provide a tangible target for the patient's hostilities. Other psychotic factors of delusional disorders and shared psychotic disorders. Clinical observations indicate that many, if not all, paranoid patients experience a lack of trust in relationships. A hypothesis relates this distrust to a consistently hostile family environment, often with an over-controlling mother and a distant or sadistic father. Erik Erikson's concept of trust versus mistrust in early development is a useful model to explain the suspiciousness of a paranoid individual who never went through the healthy experience of having his or her needs satisfied by what Erikson termed the outer providers. Thus, they have a general distrust of their environment. Defense mechanism. Patients with delusional disorder use primarily the defense mechanisms of reaction formation, denial, and projection. They use reaction formation as a defense against aggression, dependence needs, and feelings of affection, and transform the need for dependence into a staunch independence. Patients use denial to avoid awareness of painful reality, consumed with anger and hostility, and unable to face responsibility for the rise. They project their resentment and anger onto others and use projection to protect themselves from recognizing unacceptable impulses in themselves. Other relevant factors. Delusions have been linked to a variety of additional factors such as social and sensory isolation, socio-economic deprivation, and personality disturbance. Deaf and virtually impaired individuals and possibly immigrants with limited ability in a new language may be more vulnerable to delusion formation than the normal population. Vulnerability is heightened with advanced age. Delusional disturbance and other paranoid features are common in elderly adults. In short, multiple risk factors are associated with the formation of delusions, and the source and pathogenesis of delusional disorders per se have yet to be specified. Now, let's talk about the diagnosis and clinical features of delusional disorder. The 5th edition of the Diagnostic and Statistical Manual of Mental Disorders, DSM-5 criteria for delusional disorders are listed. Risk factors associated with delusional disorder are advanced age, sensory impairment or isolation, family history, social isolation, personality features like unusual interpersonal sensitivity, recent immigration. Now let's talk about mental status. General description. Patients are usually well groomed and well dressed without evidence of gross disintegration of personality or of daily activities. Yet they may seem eccentric, odd, suspicious, or hostile. They are sometimes litigious, litigious and may make this inclination clear to the examiner. The most remarkable feature of patients with delusional disorder is that the mental status examination shows them to be quite normal, except for a markedly abnormal delusional disorder system. Patients may attempt to engage clinicians as allies in their decisions, but a clinician should not pretend to accept the delusion. This collusion further confounds reality and sets the stage for eventual distrust between the patient and the therapist. Mood, feelings, and affect. Patients' mood are consistent with the content of their delusions. A patient with grandiose delusions is euphoric. One with persecutory delusions is suspicious. Whatever the nature of the delusional system, the examiner may sense some mild depressive qualities. Perceptual disturbances. By definition, patients with delusional disorder do not have prominent or sustained health in hallucinations. A few delusional patients have other hallucinatory experiences, virtually always auditory rather than visual. Thought. Disorder of thought content in the form of delusions is the key symptom of the disorder. The delusions are usually symptomatized and are characterized as being possible or delusional, delusions of being persecuted, having an unfaithful spouse, being infected with a virus, or being loved by a famous person. These examples of delusional content contrast with the bizarre and impossible delusional content in some patients with schizophrenia. The delusional system itself can be complex or simple. Patients lack other signs of thought disorder, although some may be verbose, circumstantial, or idiosyncratic in their speech. What they talk about their delusions, clinicians should not assume that all unlikely scenarios are delusional. The veracity of the patient's beliefs should be checked before deeming their content to be delusional. Sensorium and cognition. Orientation. Patients with delusional disorder usually have no abnormality in orientation unless they have a specific delusions about a person, place, or time. Memory. Memory and other cognitive processes are intact in patients with delusional disorder. Impulse control. Clinicians must evaluate patients with delusional disorder for ideation or plans to act on their delusional material by suicide, homicide, or other violence. Although the incidence of these behaviors is not known, therapists should not hesitate to ask patients about their suicidal, homicidal, or other violent plans. Destructive aggression is most common in patients with a history of violence. If aggressive feelings existed in the past, therapist and should ask patient how they manage these feelings. If patients cannot control their impulses, hospitalization is probably necessary. Therapist can sometimes help foster a therapeutic alliance by openly discussing how hospitalization can help patients gain admission control on their own. Judgment and truth. Patients with delusional disorder have virtually no insight into the condition and are almost always brought to the hospital by police, employees, for family members, or judgment. Can be assessed by threatening the patient's past, present, and planned behavior. Reliability. Patients with delusional disorder are more likely to cause reliability and when it impinges on patients with delusional disorder are usually coincidence about their delusional system. Types: precursory type, jealousy type. Now we will just simply talk about jealousy type, which is in English literature, in Shakespeare, called Othello syndrome. Delusional disorders. Disorder with delusions of infidelity has been called conjugal paranoia when it is limited to the delusion that a spouse has been unfaithful. The eponym Othello syndrome has been used to describe morbid jealousy that can arise from multiple concerns. The delusion usually affects men, often those with no prior psychiatric illness. It may appear suddenly and serve to explain a host of present and past events involving the spouse's behavior. The condition is difficult to treat and may diminish only separation, divorce, or death of the spouse. Marked jealousy are usually termed pathological jealousy or sorbid jealousy. Marked jealousy, usually pathological jealousy, for which treatment is directed at the primary disorder. Delusion, jealousy is a powerful emotion. It can be potentially dangerous and has been associated with violence, notably both suicide and homicide. Suicides and homicide. The forensic aspects of the symptom have been noted repeatedly, especially its role as a motive for murder. Physical and verbal abuse occur more frequently, however, than do extreme reactions, allowing individuals with this system caution and care in deciding how to deal with such representation are essential not only for diagnosis but also from the point of view of society. Now let's talk about a case where the person is suffering from jealous type, paranoid, conjugal paranoia, pathological jealousy, or morbid jealousy. Mr. M was a 51-year-old married man who had lived with his wife in their homeland, and his death works full slow. He began to follow her, kept notes on his observation, and badgered her constantly about this, often waking her up in the middle of the night to make accusations. Shortly before admission, these arguments led to physical violence about his wife's fidelity. Mr. M reported feelings of depression over his wife's betrayal of their marriage vows, but he noted no changes in sleep, appetite, or work-related functioning. He was treated with a low dose of an antipsychotic medication and described being less concerned about his wife's behavior. After discharge, he remained on medications and was seen by a psychiatrist monthly, but 10 years later, he continued to believe that his wife was unfaithful. His wife noted that he sometimes became upset about the delusion, but that he had not become aggressive or required readmission. This patient experienced a fixed encapsulated delusion of jealousy that did not interfere with his other activities and that showed a partial response to antipsychotic medications. Although he initially reported feeling somewhat depressed over his wife's perceived infidelity, he did not have other symptoms suggestive of a major depressive episode. So, this is all about morbid jealousy or jealous type, morbid jealousy, pathological jealousy, or Othello syndrome. জি, এটা হলো